Good morning. My name's Andrea Veatch. I'm a medical oncologist, and I'm happy to have the opportunity to talk to you today about lung cancer and some of the advances that have taken place in the field of lung cancer. I would also like to thank the Survivorship Conference organizers for putting this on in a virtual setting so that we can continue to reap the benefits of this conference despite the COVID times right now. Going to speak about the evolution of lung cancer treatment and some advances that have occurred. As you may be aware, when a person is diagnosed with lung cancer, they quickly rack up several doctors, a surgical oncologist, a radiation oncologist, and a medical oncologist. I'm a medical oncologist, which is the doctor that gives systemic treatment in terms of intravenous therapy or oral therapy that treats the entire body. Surgical oncologists, of course, perform surgery, and radiation doctors focus on radiation treatment. I'm going to speak about non-small cell lung cancer. There's basically two classes, squamous cell and non-squamous cell. Non-squamous includes adenocarcinoma, which is the largest group of lung cancer, and there's some other histologies that are less common, including large cell adenosquamous, sarcomatoid, and some others. This is a historical graph that shows the survival at each stage at the time of diagnosis. Stage 1, historically 10% of patients diagnosed with lung cancer had stage 1 disease, and this 5-year survival is in the 60% range. Stage 2, approximately 20%. Stage 3 includes 30% of patients, and the majority of patients have stage 4 disease with a 5-year survival of less than 5%. This is how the stages are defined. Stage 1 is limited to one lobe of the lung. Stage 2 is defined as a tumor that is involving the lobe of the lung as well as the lymph node, at least one lymph node within the lobe of the lung. And stage 3 is when the cancer has spread to the lymph nodes that are located in the middle of the chest, called the mediastinum. Stage 3 means the lymph nodes are involved on the same side as the tumor, and stage 3B, the lymph nodes are involved on the opposite side of the mediastinum compared to the lung cancer. Stage 4 is when the cancer has spread through the bloodstream to another area of the body. I'm going to talk about stage 1 lung cancer first. This is an image that shows a tumor. It would not be both tumors, just one tumor in one lobe of the lung. It's only in the lung and no lymph node involvement. This is a radiographic image. On the left side is a chest x-ray, and the right is a CAT scan. This is the same patient, the same tumor, and this just demonstrates the ability to see things more clearly on a CAT scan. And this is a 3-centimeter tumor in the left lower lobe. So stage 1 lung cancer is a tumor size from 0 to 4 centimeters. 1 inch is 2.4 centimeters, and so that gives you a sense of about 1.5 inches or less, without any lymph node involvement and no spread. The treatment for stage 1 lung cancer is local therapy, which means either surgery or radiation. Generally, there's no systemic treatment for stage 1 lung cancer. It's local therapy. Either remove it or treat it with radiation. Surgery is commonly used in early stage lung cancer, stage 1 and stage 2, sometimes stage 3. There's 2 types of surgery. The classic older version, original version of lung cancer surgery involved an open thoracotomy, which is a large incision throughout the flank of the body around to the front. More modern treatment is a video-assisted thoracoscopic surgery on the left side. This involves usually 5 incisions and as video-assisted technology, which is quite precise. So the VATS procedure is considered the standard of care. The incisions are smaller, so there's less tissue damage, less blood loss, less time in the operating room, less recovery time, less hospital time, and less expense. The scars are smaller. There's therefore a reduced chance of postoperative wound complications, and in experienced hands, it's more accurate. So this staging can be fine-tuned. Sometimes it's the stage prior to surgery is inaccurate and is defined further at the time of surgery. In one study, 30% of patients, their tumor was upstaged, meaning that it was worse than expected, a higher stage than expected, and 12% was downstaged, meaning that the spread of the tumor was actually better than expected. As far as advance in radiation, stereotactic body radiotherapy is a very focused, very intense radiation treatment that's used in early stage lung cancer when a patient is inoperable for whatever reason due to the health of their lungs, or even if the patient just chooses against surgery. This type of radiation has very high rate of tumor control, meaning the actual tumor that's treated, the chance of all the active live tumor in that tumor are killed with radiation is very high. Yet there is still a risk that some cancer has spread out of the tumor prior to the radiation, and that could result in metastatic disease at a later date. SBRT is also used in metastatic lung cancer when a patient has 5 or less areas involvement and they've been on treatment and responding well. There's clear data to support radiation therapy for metastatic disease in less than 5 lesions with a significant improvement in survival. SBRT has less toxicity than standard radiation. It's administered with less fractions, 5 versus 33 to 34 treatments. There are some complications involved because the dose is quite high. There can be significant inflammation at the site of the tumor, which on radiographic imaging looks like pneumonia or pneumonitis. Can cause symptoms such as cough and shortness of breath. If the tumor is too close to the airways, it can cause damage to the airways, and if it's too close to the chest wall, it can cause damage to the chest wall, including rib fractures and chronic pain. This is an image of stereotactic body radiotherapy, and just to demonstrate that it's a 3-dimensional process, and the point at the center receives the maximum dose of radiation, and then there's very rapid fall off of the radiation exposure to the surrounding tissue. The idea being to protect the normal tissue as much as possible and to give a very precise dose of radiation. Stage 2 lung cancer is defined as a tumor that has spread to a local lymph node within the same lobe of the lung. Here's a picture of this in right upper lobe tumor that has spread to a hilar lymph node. This is not a mediastinal lymph node, but within the parenchyma of the lung tissue. The lymph node involvement in stage 2 lung cancer is N1, which means hilar lymph nodes that are within the lung. This is an image that shows the tumor in red, and then the green lymph nodes are considered N1. The mediastinal lymph nodes are the N2 and N3 in orange and yellow. Stage 2 lung cancer, again, is involving the lymph nodes within the lung. And sometimes the lymph nodes are not visible on imaging. And so sometimes a person can be treated for stage 1 lung cancer, and yet it has already spread to the lymph nodes within the lobe of the lung and is actually stage 2. That's the reason why surgery is the standard of care for stage 2 lung cancer rather than stereotactic body radiotherapy. because those subtle lymph node involvement within the lobe of the lung would not be treated by stereotactic body radiotherapy. So the treatment of stage 2 lung cancer is surgery followed by chemotherapy or radiation given concurrently with chemotherapy. I think I said that wrong. Surgery followed by chemotherapy or radiation given concurrently with chemotherapy. Again, surgery is the primary treatment for early stage lung cancer. And this is, again, as I mentioned, if there's hilar involvement of the tumor that's not seen on imaging, it can be missed with SBRT and result in a subsequent recurrence in the hilum and the mediastinum. Adjuvant chemotherapy means chemotherapy after surgery. So adjuvant chemotherapy is standard of care when a tumor is more than 4 centimeters in size. This would be stage 1B to stage 3 lung cancer. And this course of chemotherapy is usually 4 cycles of treatment. The drugs that are used depend upon the histology that's identified at the time of surgery. There has been a survival benefit to the use of chemotherapy, increasing the percentage of people alive at 5 years by 5 to 10%. Again, the choice of chemotherapy depends on the histology. Adenocarcinoma is the most common type of lung cancer, and the chemotherapy given in that setting is cisplatin and pemetrexed. The non-adenocarcinoma histologies, squamous cell and other types can be given with a variety of combinations of chemotherapy, none of which have been demonstrated to be superior than the others. The treatment course is 4 cycles. Each cycle is 3 weeks long, so approximately 12 weeks of treatment. A new advance in lung cancer since last year is the use of adjuvant targeted therapy for EGFR positive lung cancer. This is a subset of lung cancer that expresses a mutation called EGFR. The patients in this clinical trial that was recently presented, patients had a complete resection with surgery. This was followed by the standard chemotherapy, as mentioned before, and then the patients were randomized to either a standard anti-EGFR medication, osimertinib, versus a placebo. The disease-free survival was 89% versus 53%. The overall survival was not included in the data because it was unblinded early due to the results being very positive. So this is in the process of becoming more intriguing, but is at this time is not considered standard of care, although it would likely become standard of care over time. The problem is that the overall survival data is really important to determine standard of care, because if a person is already cured by the surgery that they've had in the adjuvant chemotherapy, then a large percentage of patients will be given treatment targeting their EGFR mutation, which maybe they did not need. Stage 3 lung cancer is a big, broad category with a lot of different complicated subtleties, but I just want to kind of give an overview of stage 3 lung cancer. Again, this means it's involving the N2 lymph nodes, which are shown in orange. These are in the mediastinum, which is a space distinct from the lungs in the middle of the chest around the heart and the airways. The orange lymph nodes are N2 lymph nodes and the yellow are N3. So stage 3A lung cancer is defined as the N2 lymph node involvement, and stage 3B is involving the yellow lymph nodes. There's a lot of different variations of treatment for stage 3 lung cancer. The most common treatment is chemotherapy given concurrently, meaning overlapping with radiation. And this has changed since last year when I presented the same presentation. Previously, the standard of care was to give radiation, which is a 7-week course of treatment, concurrently overlapping with chemotherapy, 4 cycles, each cycle 3 weeks. And that was the standard of care for many years until within the last year or two, there's been significant transition towards giving the patient radiation for 7 weeks, which has not changed, chemotherapy for 2 cycles during the radiation treatment only, and then this followed by 1 year of immune treatment with a drug called durvalumab. This is now the standard of care for stage 3 unresectable lung cancer. There are some situations when surgery is performed in stage 3 lung cancer, for example, if the N2 disease was not detected in the staging studies prior to initiation of treatment, or if there is a small tumor and a single lymph node involved, there are times when a lobectomy will be performed first, and then this would be followed by chemotherapy and or radiation. This is an example of a T3 tumor, just to basically show what a cancer looks like in the lungs. This is defined as T3 with an X-ray on the left and a CAT scan on the right. And this is a T4 tumor, more involved, more advanced, larger, more invasive. It can involve structures of the chest wall or the airway, the middle of the chest, the heart, the esophagus, and or be greater than 7 centimeters. As I mentioned, the new standard of treatment for stage 3 lung cancer is to add 1 year of immune treatment after the chemotherapy and radiation. This was approved after presentation of a study called the Pacific study, which was presented in the New England Journal of Medicine. Patients with unresectable stage 3 lung cancer were treated with concurrent chemotherapy and radiation, followed by 12 months of immune therapy with a drug called durvalumab or Imfinzi. Again, the historical 5-year overall survival for stage 3 lung cancer from the first graph that I showed was 5 to 30%. So in this, just to put it in perspective, in this trial, 700 patients were randomized to either concurrent chemoradiotherapy to concurrent chemoradiotherapy followed by immune therapy. The time progression-free survival means the time until the cancer progresses, and it was 5.6 months in the patients who did not receive the immune therapy versus 16.8 months in the patients who did. And that is the mean. It's not, of course, all patients did not have a recurrence at 16 months. It's more the middle of the bell-shaped curve. The 12-month survival rates were 75% versus 83%. The 24-month survival rate was 55% versus 66%. And the 3-year survival was 44% versus 57%. And so this is a 57% 3-year survival in stage 3 lung cancer compared to a 5 to 30% survival at 5 years prior to the use of this combination of treatment. And now I'd like to talk about stage 4 lung cancer, which is the most common type of lung cancer. It's not curable, but there has been significant advances in stage 4 lung cancer. The biggest question on people's minds that comes up every day is it really even worth treating stage 4 lung cancer? Is it just too much? Is it going to be too toxic and not even any gain from it? And so this is obviously a big question for everybody. There was a large meta-analysis trial looking at 2,714 patients and basically just look at patients that were treated versus not, and what percentage were alive at 1 year. And the difference was 29% versus 20% 1-year survival. And that was all different kinds of histologies, all different kinds of chemotherapy, but there was a 9% benefit at 1 year as far as the percentage of people alive. So there's been a lot of advance in terms of stage 4 lung cancer treatment. The first question is always, what type of lung cancer is it? And this is determined based on the immunohistochemistry results of the pathology. And that defines the tumor as either squamous cell or non-squamous cell. The non-squamous includes adenocarcinoma and several other histologies. Further testing is done prior to initiation of treatment, which includes molecular characterization of the tumor. These are mutations that predict sensitivity to targeted therapies, and PD-L1 testing, which is a measure of a protein on the tumor cell or on the surrounding tissue that predicts sensitivity to immune therapy. These tests are all done prior to initiation of treatment with a patient with stage 4 lung cancer. So again, the type of cancer is determined, the molecular testing or the mutation testing, and the PD-L1 testing. Molecular testing is standard of care for metastatic lung cancer, and this is looking for a specific driver mutation that are well known and well documented in advance. These mutations are assessed, and if there is a mutation, then there's a approved targeted therapy that can be given specific to that patient. This would be in place of standard chemotherapy. It's more effective than standard chemotherapy. It's oral drugs, and so it's more convenient. The toxicity is generally milder, the survival is generally greater, and the quality of life is generally significantly better. These are, actually, let me put me over here out of the way. These are the common, some of the common mutations that are routinely checked in lung cancer prior to initiation of treatment. It does require some time to get these results, and this does require patience on the part of everybody involved. But the common targets are EGFR, which is the most common mutation that is a driver mutation in lung cancer, ALK mutation, ROS1, BRAF, and TKF. There's other mutations that are checked frequently, including HER2, MET, and RET. So these are mutations that are routinely checked. There's a broader testing called next generation sequencing, and what that is testing all of the mutations of the tumor in a more broad test that can actually be cheaper than sending out for each of the individual mutations, and you get a broad picture of the mutations involved in the cancer. Not always the information is clinically relevant, but it does give you a broader picture, and sometimes it can give you some targets that can be used after the standard of care. This is a pie chart showing all lung cancers and then the percentage of the different mutations that are seen. And so as you can see in the gold on the right lower quadrant, the EGFR mutations, those are the most common targetable mutation. And then ALK, and then as you go down onto the left lower quadrant, all of the different mutations. So there are 32% that are unknown, and on the left upper quadrant, and the KRAS on the right upper quadrant is not a targetable mutation, but rather a mutation that indicates a poor prognosis and lack of sensitivity to targeted drugs. This is just a common, this is just a representation of a report that we would get if we sent next generation sequencing. It shows first the somatic mutations and then the germline mutations. Somatic are acquired during a person's lifetime. Germline means a person was born with that, so it would be like a hereditary predisposition for cancer would show up in that area. The pertinent negatives in a patient that has lung cancer, these mutations that are mentioned in the middle, EGFR, KRAS, and so on. Those are the mutations that are frequently checked in lung cancer patients. The next section is immunotherapy markers. Tumor mutation burden is a measure of the mutations, like a measure of the mutations in the cancer, and that predicts sensitivity to immune therapy. And then the bottom half of the report talks about clinical trials that may be relevant for a patient. I want to talk about liquid biopsies. This is new from last year. The liquid biopsy is a way of getting molecular information without a biopsy. And this is convenient when tumor tissue obtained at biopsy is inadequate, or if the tumor is not accessible, or if there's if it's dangerous for whatever reason, the tumor tissue was not adequate for molecular testing, then the liquid biopsy is a substitute for that. This is a blood test where circulating DNA is obtained. Essentially, when a cancer cell dies, it releases the DNA into the bloodstream. The fragments of DNA can be obtained from a blood sample, and then they can be measured in the same way that the tumor testing is done for molecular markers. It's very specific, not very sensitive. In other words, there can be a high false negative rate. The test is best when there's bulky cancer involved. That way there's more circulating tumor DNA involved. If it's a small cancer that was removed, or a small cancer that has a slow turnover, then the circulating tumor DNA may be read as negative, but it may be a false negative. I'm just going to go briefly through the couple most common mutations. The EGFR mutation, again, like 15 to 17% of lung cancer. It is more frequent in non-smokers, it's more frequent in women, and it's more frequent in Asians. And so an Asian woman non-smoker would have a very high likelihood of having an EGFR mutation. They're treated with EGFR targeted therapy, which has been shown to be superior to chemotherapy, meaning the targeted therapy is given in place of chemotherapy. EGFR first-line therapy currently is osimertinib, which has a response rate of 80%. A subset of EGFR mutations. So there's an EGFR class of mutations, and then within that, there's different mutations in the EGFR mutation. So the most common is deletion 19, and that group of patients has a median overall survival of 45 months. Again, this is stage 4 lung cancer. And just to remind you, the graph at the beginning, stage 4 lung cancer survival less than 5% at 5 years. And here, this group of patients has a median overall survival of almost 4 years. The ALK mutation is another mutation that's seen. It involves 5% of lung cancer. It's more frequent in non-smokers and young patients, mostly seen in adenocarcinoma, and the treatment is alectinib first line, which has a progression-free survival of 35 months, compared to the first-line ALK inhibitor, crizotinib, which had a progression-free survival of 10 months. I'm going to switch and talk about immunotherapy in lung cancer now. This is a graph that shows the interaction between T cells within a tumor and the cancer cell itself. The T cell is pink and the cancer cell is purple. On the two right bullets, you can see the PD-1 binding to the PD-L1 on the tumor, and the CTLA-4 receptor on the T cell binding to CD80 on the tumor cell. And once this connection is made, the T cell is rendered inactive. So the cancer cell can actually inactivate the T cells, and that allows the cancer cell to go undetected from the immune system and to grow without being seen as foreign. So this class of drugs interacts with this connection and blocks the connection between the CD80 CTLA-4 connection is blocked by ipilimumab, and the PDL1 to PD-1 connection is blocked by PDL inhibitors and PD-1 inhibitors. Once that connection is blocked, then the immune system can be basically woken up and more active, and then can target the cancer cell. The KEYNOTE-001 trial is a trial of patients that had not been treated previously and patients who had been treated previously, and they were given a drug called pembrolizumab or Keytruda. This was the only drug in the trial, and this was not a comparison to a placebo. Everybody received the drug. I just want to point out that survival of patients treated with this drug. Treatment naive means that they had not been given any treatment before. Again, this is stage 4 lung cancer. So in treatment naive patients, the 36-month survival was 37%. The 5-year survival was 23%. And with the TPS greater than 50% of the greater than 50%, which predicts a higher sensitivity to immune therapy, this 5-year overall survival was 30%, which is pretty amazing, actually. It's very amazing. Previously treated patients also showed benefit, especially if they had a TPS greater than 50%. So if you look on the right column, the 60-month 5-year overall survival percentage of all categories exceeds 5%, except for the very bottom group, TPS less than 1%, and previously treated. And so again, this drug may not be beneficial for patients with that finding. However, all of the other groups benefited with a survival that exceeded the historical claim of less than 5% at 5 years. As you can see, immune therapy is a game changer for stage 4 lung cancer, and has definitely pushed the survival duration towards longer survival. And this is the grim image I showed at the beginning of the survival historical. So the cancer cell is checked for PD-1 expression or PD-L1 expression, and there's 3 categories. One is less than 1, which means no expression. One is 1 to 49% of the tumor cells show expression, that's considered low, and greater than 50% or greater is considered high. And so when that's determined, the treatment can then be chosen. So if a patient has low or absent PD-L1, then normally the first line treatment is chemotherapy combined with immune therapy. And this has replaced chemotherapy alone as the standard of care. So pretty much everybody with stage 4 lung cancer would be treated with a combination of chemotherapy and immune therapy if they're able to tolerate the combination. The second treatment option in this setting is just immune therapy using 2 drugs. The nivolumab targets the PD-1 and the ipilimumab targets the CTLA-4, and they're combined and given to patients with metastatic lung cancer. And that's a new approval in the past year since the last conference. Patients who have high PD-L1 expression greater than 50% can be treated with immune therapy alone. That was the graph that I showed you last. This graph is the Keytruda or pembrolizumab alone without chemotherapy. If patients have a high PD-L1, but they have a very aggressive, rapidly progressive disease, then often we'll combine the immune therapy with the chemotherapy because it is more effective quickly, although it's more toxic. And so if someone has an urgent need to have the disease controlled, then we will combine it with chemotherapy to try to get it under control quickly. These are the different situations that can come up in the different drugs that are currently approved. And so if the PD-L1 is low, a patient can be treated with nivolumab and ipilimumab first line, or with pembrolizumab or atezolizumab in combination with chemotherapy. If the PD-L1 is high, they can be treated with Keytruda monotherapy or atezolizumab monotherapy. And then stage 3 disease, like I mentioned previously, this is independent of PD-L1 expression after concurrent chemoradiotherapy. For unresectable stage 3 lung cancer, patients can be treated with durvalumab for 1 year, which has shown a significantly increased progression-free survival. I'm going to switch gears and now talk about lung cancer screening. The National Lung Cancer Screening Trial looked at 53,454 patients with high risk for lung cancer, and patients were randomized to low-dose CAT scan versus chest X-ray. A low-dose CAT scan means low dose of radiation, And the high-risk population was defined by the study as age greater than 55 up to age 74 and 30 pack year history of tobacco use. Patients who had quit smoking in less than 15 years or continue to currently smoke. And this trial showed a reduced mortality of 20% by screening for lung cancer. So what that does is it catches lung cancer early. Again, stages 1, 2, and 3 are potentially curable, and those would be the population of detecting cancer would be shifted to the earlier stages, and stage migration would be seen. And so earlier stages are identified and treated and have greater survival. And so lung cancer screening is really an important point that I would like to drive home, that if you know anybody who meets these high-risk population and they have not been screened for lung cancer, encourage them to see their primary care physician and request a low-dose CAT scan for screening. And this is not just one CAT scan one time, it's annual screening. Again, the patients that are eligible are age 55 to 74. Of course, if a person is 75 or say 80 and they meet the criteria, I would argue that they would still benefit from being screened. 30 pack year history of tobacco use. Again, a pack year is 1 pack smoking for 1 year. So if a person smokes 2 packs a day, 15 years is 30 packs. If they smoke 3 packs a day, then 10 years would be 30 pack years. A current smoker or quit within 15 years, because as a person gets further from their tobacco quit date, then their risk of lung cancer goes down. And again, annual screening. Initially 3 years, 3 years of a low-dose CT scan is the standard of the clinical trial that was performed. However, the risk persists, and so annual screening, just like mammograms, is reasonable. So a person is diagnosed with lung cancer and they smoke, and they frequently ask this question: should I quit smoking? Now, I mean, I have lung cancer. Now I already have lung cancer, so why should I quit, or should I quit? And there is a strong argument that it is beneficial to quit, and here's why. So immediately when a person stops smoking, the new cells that populate the lining of the airways are not exposed to the toxins of the tobacco. So the healthy cells can repopulate the airways, and this will start immediately to benefit a patient. The damage that's done to the lungs immediately stops when a person stops smoking. The intensity of smoking at diagnosis does correlate with prognosis. And so cutting back is helpful as well, but cutting altogether is definitely much more beneficial to your body. Chemotherapy is more effective in people who quit smoking, and the reason why is because the tobacco has a lot of toxins, thousands of toxins that are inhaled, and the body has to deal with these toxins. And so the liver is the filter by which the toxins are metabolized or cleared, or at least attempted to. And in smokers, the liver is extremely efficient at trying to clear these toxins, and chemotherapy can be considered a toxin as well. And so the chemotherapy is cleared much more readily in smokers than non-smokers, and therefore the tumor doesn't see the same dose of chemotherapy as in a non-smoker. The chemotherapy that actually reaches the tumor is less than a person who is a non-smoker. Patients who quit have a lower recurrence risk. They have a lower risk of second cancers. And the good news is that most lung cancer patients do quit. 86% of lung cancer patients quit smoking within 5 months of diagnosis. After a person's been treated for lung cancer, the surveillance for recurrence is a CAT scan every 6 months for 3 years, followed by a CAT scan once a year, year 4 and 5. And the surveillance is not just for recurrence, but also for secondary primary lung cancers. In a more broad sense, the survivorship plan after treatment includes being up to date on vaccines, including annual flu vaccine, the herpes zoster vaccine, which is shingles. It's called Shingrix, which is not a live vaccine and therefore will not give a person a shingles infection. The pneumococcal series is important. It's important to maintain healthy weight and physical activity every day, 30 minutes, a healthy diet with an emphasis on plant sources, to limit the amount of alcohol, and to continue routine follow-up for general physical health, including getting the vital signs checked, cholesterol, glucose, getting dental care routinely, bone density care, sun protection, and cancer screening recommendations, for example, colonoscopy, mammogram, pap smears, prostate cancer. This is the summary of what I spoke about today. Improvements in survival have been seen as a consequence of all of these advances: minimally invasive surgery, stereotactic body radiotherapy, the use of adjuvant chemotherapy after surgery for stage 2 lung cancer, the use of adjuvant immunotherapy after concurrent chemoradiotherapy for stage 3 lung cancer, the use of adjuvant targeted therapy for stage 2 and 3 resected lung cancer in EGFR positive patients, the use of immunotherapy with chemotherapy for stage 4 lung cancer, the use of immunotherapy alone in stage 4 lung cancer with high PD-L1 expression, the use of targeted therapy, the testing with next generation sequencing, the use of liquid biopsies for molecular testing, and again, screening saves lives. That's not brand new, but it's really, really important. The most important thing of all is the lung cancer screening. And if there's one thing that I would like to convey with this is to, if you could all please find one person in your life that has not been screened for lung cancer but meets the criteria, encourage them to have a screening low-dose CT scan for lung cancer, and it might save their life. And that's all I have. Thank you very much. Thank you for attending, and have a wonderful day.